So, hello everyone. I hope you can hear me. I welcome all of you to this lecture series for education for pediatric radiotherapy, which is organized in collaboration by West Germany Proton Center in Essen, cross-working group of SIAP Global Health Network and Pediatric Radiation Oncology Society. So, Beate, I would request you to take over and introduce the topic and Akmal.
Yes, thank you very much, Bilal. Yeah, we are very happy that we have now our second educational event here on radiotherapy in bone sarcomas, and I'm very happy that Akmal Safwat, Associate Professor at Aarhus University in Denmark, agreed to take over. He is very busy in soft tissue sarcomas, but of course also bone sarcomas, and he is a dear friend in the European Ewing Consortium and very busy and knowledgeable. So we are looking forward, Akmal, to your presentation on radiotherapy in bone sarcomas. Please go ahead.
Thank you very much, Beate, and thank you for the invitation, and it's a great pleasure to be here today. Let me see the first slide. I'm sorry, it's not me who is sharing, but I think we can manage. As Beate said, my name is Akmal Safwat, and I am a radiation oncologist in the National Danish Proton Center in Aarhus. And this is the picture of our center in Aarhus. Next slide, please. You see where the Proton Center is situated in Aarhus University Hospital, which is on the north side of Aarhus, the second biggest city in Denmark. Next slide. So first, what to expect of this lecture? Well, it's a role of radiotherapy in bone sarcoma. So I didn't focus on any biology or pathology or epidemiology. I didn't focus on chemotherapy or immune therapy or any fancy new drugs. I just focused on basic radiotherapy treatment. I focused on hands-on educational aspects, such as indication of radiotherapy, timing of radiotherapy, margins, fractionation, etc. This is at least my experience, the need of my colleagues here when I give a lecture, because sarcoma is such a rare disease, and they need something to help them deal with cases whenever they meet one. Although in Denmark it is centralized treatment, sarcoma treatment, so very few doctors actually deal with radiotherapy of sarcomas and chemotherapy of sarcomas, but still younger doctors need to know something about how to deal with this disease. Next slide. So the lecture outline is that I will, of course, give a short introduction about bone sarcomas and some general radiotherapy considerations. Then I will talk about the radiotherapy of chemosensitive pediatric sarcomas. I mean by that Ewing sarcoma and osteosarcomas. And then I will move to the radiotherapy of the chemo-resistant pediatric bone sarcomas, focusing on chordomas and chondrosarcomas. I will then zoom in a bit and to talk about the challenges of skull-based tumors, because they are challenging in many ways. Slightly mention some aspects of late side effects, especially about the skull-based tumors. And then I have one slide that I tried to say something specific about low and middle income countries. Next slide. So bone sarcomas, where do they come from? I mean, bone sarcomas arise from a malignant transformation of a mesenchymal stem cell that has the ability to differentiate into bone or cartilage. And we understand sarcomas the same way as we understand hematological diseases. So you find a similar picture to this on the right, the mesogenic process in hematological physiology and diseases as well. The mesenchymal stem cell has the ability to differentiate and then commit into a particular line of differentiation. It can give bone and cartilage or muscle or endothelial cells, any other cells. And we know from, for example, liposarcoma studies like the one on the left side, that not only that we know the differentiation from mesenchymal stem cells to fat cells, but we also know that when the event, the oncogenic event occurs in this differentiation process, it can lead to a particular subtype of liposarcoma. And the reason I mentioned that is that because sometimes we see, it explains why sometimes we see liposarcomas as primary tumors in bone, or angiosarcomas, or we see osteosarcomas in soft tissue. It is because this mesenchymal, the stem cell, has the ability to differentiate, and before it commits itself to a particular differentiation line, it can give different pathologies. Next slide. And this gives a lot of pathological subtypes. I don't need to go through them all. You know how difficult the situation is. But for bone sarcomas, I will mention the osteo, the Ewing, the chondrosarcoma, and the chordomas, and maybe briefly about the giant cell tumor. Next slide. The causes for sarcoma in general, in children, the majority are spontaneous. There are some genetic disorder that predisposes to sarcomas or previous irradiation. On the right-hand side, a case that I had in Denmark, a 16 years old girl, previously treated for bilateral retinoblastoma with irradiation from both sides, and 15 years later, she developed an osteosarcoma from the base of skull, as you can see here. Next slide. So now we focus on the radiotherapy. There are general indications for radiotherapy in pediatric sarcomas in general, and bone sarcomas, of course. And these are a list of these general indications. Because surgery is extremely important. It is a major local treatment modality. And if the tumor is irresectable, we think about radical radiotherapy. If the surgery is refused by the patient because it is too mutilating, often we talk about amputation or disarticulation, then we can think of radiotherapy. If the margin is expected to be marginal in the MDT before the surgery, then sometimes you can think about preoperative radiotherapy in soft tissue sarcomas, but also Ewing sarcoma. If the margin after the surgery is inadequate and you cannot salvage that with another surgery, then you think of postoperative radiotherapy. If there was spread to regional lymph node, it's not often in bone sarcoma, but it can happen, and it happens also with soft tissue sarcoma, then you have to irradiate the node, even if they were removed surgically. And generally, the doctors can sometimes decide if they feel that the risk of local failure is high because of other factors, poor response to chemotherapy, for example, or because the disease is recurrent, or because of the size or the site, I mean, like in the ribs or paravertebral, then radiotherapy is indicated postoperatively. Next slide. So these are general indications for radiotherapy. I would like also to give some general description of some basic concepts and give examples. So whenever we irradiate, we need to think of a GTV and a CTV. And the general principle for the GTV is that it is the visible tumor on imaging prior to any treatment. And GTV with pushing borders, with pushing margins, without initial infiltration, extending into body cavity, require to be modified. And here is an example. You can see a tumor in the rib that goes inside the cavity, the thorax cavity. It's not infiltrating, it just pushed it. And if after chemotherapy, this has regressed, then the line that I am drawing on the far right and above, this is the GTV modified after it has regressed. So this is an example of how you modify the GTV before you generate a CTV for this case. The GTV also should include a contact areas. Now I go into the lower panel. The GTV bit should define the contact areas prior to chemotherapy. So on the left-hand side, a larger tumor, again from the ribs, it grows into the midline, it touches on the pericardium, and it has regressed and operated. And when you define the GTV, you define the surface that has been touched by the contact area by the previous GTV, as you can see in the magenta line on the right-hand side in the lower panel. Next slide, please. General principles for CTV. It should, as we know, include the microscopic disease, including the biopsy or drain operation, the biopsy drain or operation scar. But this is only for the low risk volume, the CTV1, the lower dose, and only part of the scar can be irradiated. I mean, the surgeons sometimes take huge scars, big scars, to make it easy for them to operate. You don't have to include the whole scar beyond the CTV. I don't usually do that, only the scar within the CTV1. If they boost the dose, the higher dose, I don't include the scar. The prosthesis as well had to be involved, but only as a part of the prosthesis that is within the CTV. The CTV should be modified according to anatomical barriers such as the bone and flesh. And this is easier said than done. I mean, when we, in practice, this can be difficult and it can vary from one doctor to another. But keep that in mind whenever you do CTV or generated CTV, and we can discuss that later also and see some examples as I go with the discussion. It should also include the contact area of the previous tumor. As I showed you in the GTV, the CTV extended along the same planes. In flat bones like the sternum and ribs and frontal bone or parietal bone and the ilium, you can, when you generate the CTV, take the whole bone if it doesn't exceed 3 centimeter margin. I mean, this is, again, up to discussion. I mean, I'm not saying things that is written in stone, I mean, but this is a general principle. It's often possible and to do that. In long bones, you should include the whole bone if there is an intramedullary involvement or lesions. So these are general principles. It applies to both osteo and sarcomas and Ewing sarcoma, and generally to other types of sarcoma as well. Next slide. Now we go from the general aspects to some specifics, and we will discuss the role of radiotherapy in the chemosensitive pediatric bone sarcomas. Next slide. So you can see that the treatment algorithm of Ewing and osteosarcoma in general are similar in basic principles. Here on the right-hand side, you can see that both are treated with neoadjuvant, aggressive, multi-agent chemotherapy. And then you apply a local therapy where surgery plays a major role in both, particularly for osteosarcoma. Then radiotherapy can sometimes be added following surgery or preoperatively. And then there comes a phase of an adjuvant chemotherapy before the patient finishes the treatment. So this is the general principle. Ewing sarcoma is relatively radiosensitive than osteosarcoma, and radiotherapy often plays a major or a larger role in treatment of this disease. The standard doses, because of their radiosensitivity, varies between 45 and 60, but there is, of course, an idea of dose escalation. Now, the new protocols also always talk about dose escalation for Ewing sarcoma, of course, for the high-risk group of patients that needs this dose escalation. For osteosarcoma, on the other hand, the standard doses start from 60 and up to 72 grays. The difference between Ewing and osteosarcoma is that we often defer or delay the radiotherapy to after the end of chemotherapy. Partly because the side effects of trying to give radiotherapy and chemotherapy concomitantly, use high dose of methotrexate, use doxorubicin, you cannot omit that. And partly because there is no data that an earlier treatment is essential and needed for osteosarcoma, whereas in Ewing sarcoma, there are data to say that you need to start the treatment early. The local treatment, I mean. Next slide. So Let's go into some details about the radiotherapy of Ewing sarcoma. Next slide. Again, we talk about the indications, and we have indications for preoperative radiotherapy or to consider preoperative radiotherapy. This is when you have a patient that started with an emergency like spinal cord compression. Here you need to intervene rapidly, and you can, in certain cases, think of radiotherapy at the beginning. This is a practice not everywhere, but in Scandinavia, there has been a tradition of starting sometimes when a patient starts with an emergency with radiotherapy, and it helps. In tumor progression under chemotherapy, you can consider giving a preoperative radiotherapy. If there is metal implants, or you expect to have metal implants that will hinder the use of proton therapy, then you can consider use preoperative radiotherapy, or if there is a marginal resection or is expected marginal resection. If the surgeon tells you, I can only do marginal resection, then you can consider preoperative radiotherapy. These are possibilities, situations where you can consider that if you have the experience and you have a tradition of doing that. For postoperative radiotherapy, you can consider that when there is a poor histological response to induction chemotherapy, or if you have done a surgery at the time of diagnosis. So again, a case of emergency, you have to start with surgery before the chemotherapy. So you start with the surgery. In this case, you usually give the chemotherapy. You have nothing to guide you whether the response is good or bad, and because of that, there is an indication for giving postoperative radiotherapy. This is a European practice. These two things are mainly European practice. The Americans have different practice. I will touch upon that as well. If the surgery margin is inadequate, and you cannot do a second surgery, or you do and still it is inadequate, then you have to give postoperative radiotherapy. And in certain sites, regardless of the margin, even if it is R0 resection, pelvis, spinal, paraspinal, ribs, pleura, parameningeal sites, where you, because of the difficulty of operation and because of the anatomical site, you need to add postoperative radiotherapy to the surgical treatment. And whenever there is a pathological fracture of bone, then there is an indication for postoperative radiotherapy. A definitive radiotherapy given when there is an irresectable tumor or a partial, or the patient didn't want to get the operation because it is too mutilating for the patient or the patient and family. Now I would like to go slightly in depth about the European and American practice of the poorest histological response, because the argument in the European protocols for giving postoperative radiotherapy when there is a poor response to radiotherapy is the data that following R0 resection, postoperative radiotherapy to poor histological responders did actually improve the results and reduce the local failure from 12% to 5%. And in this study, they measured the less than 90% necrosis as the marker for the poor responders. And the argument is also that we know that survival after local recurrence is poor, then you have to reduce the risk of local failure by giving the radiotherapy. Although the impact of improving this local recurrence by adding radiotherapy on survival is not very much clear yet, but this is the argument. So R0 in poor responder is not enough as a local treatment, and you add postoperative treatment. The Americans, on the other hand, will argue that a systemic therapy is the thing needed in these cases. Its intensification will improve both local and systemic local recurrence, as well as overall survival. they also argue that the predominant mode of failure in these patients with poor histological response is systemic. Yes, there is a local failure, but the predominant mode of failure is systemic. And hence, there isn't this urge to add something local for this patient. R0 in the American protocols are not in itself an indication for adding postoperative radiotherapy. You have to take in consideration here that their definition for poor response to chemotherapy sometimes vary between less than 100% prognosis or 95%. Next slide. So these are the indications for treating the local disease, and but there are other indications when there is, of course, a lung metastasis. You add whole lung irradiation, and the dose depends on the age: 15 gray for less than 14 years, or 18 gray for more than 14 years. If the patient presented with a rib disease and pleural effusion, even if this effusion is not having proved to have malignant cell, there is an indication of having a hemithorax irradiation. Again, the dose depends on the age. And of course, there is the indication of giving radiotherapy to oligometastasis, like in the lungs or bone, sometimes the brain and other sites. If you find that feasible, if it is possible to do, then you add the radiotherapy to the oligometastatic sites. Next slide. So, which dose to give? I find actually the IU Ewing protocol very describing that very nicely. And the standard arm in this protocol divides the patient into a low risk and high risk in the adjuvant setting, and low risk and high risk in the definitive setting. With doses that goes up according to the size. I like this stratification. I think it's nice. I think it's very pedagogical in many ways, and the people can use it to see that, okay, you have a group of patients with negative margin but poor response, or a marginal resection and a good response, or a site that's high risk, and or a patient that has to be operated at the beginning. The operation is okay, but because you lack the effect of chemotherapy criteria, then you add radiotherapy and you give the lowest dose, and which is 45 gray. While another group of patients that is with a higher risk, because the margin is now intralesion resection with microscopic residual, or a marginal resection, and you have or a poor response and the pathological fracture, then you add you increase the dose to 50 gray, and so on. I mean, I don't have to read it to you, but I think this is a very pedagogical way of looking at the different risk groups and how the dose increases as the risk increase. Next slide. The margins that you have to add to CTV, if you read different protocols, you find different margins. The difference is not huge, but it's interesting to see that in the Ewing 2012, the margin from the pre-chemotherapy was between 1.5 to 2. In the IU-Ewing, it's 1 to 2, and the current inter-Ewing, it's 1 centimeter. And the CTV margin is 1 to 2 for the Ewing 2012. It's only half a centimeter in the current inter-Ewing and 1 to 2 centimeter in the inter-Ewing. So, I mean, generally, things converge at the end, because you generate a big margin, but then you modify it, because again, as we said, there is a fascia, there is a bone, there are things that has to be taken into consideration. So this margin is being shaped a little bit, and they converge. But it's interesting to see that there are different practices and different ways of looking at the margins. And I think in general, the tendency is to try to make it slightly smaller, of course, within limits, as we can see in the inter-Ewing study. Next slide. Just a remark that many of you probably know, but it's worth remembering that when you give chemotherapy, when you give radiotherapy, you give it concomitantly with chemotherapy, and some chemotherapeutic agents act as a radiosensitizer. They achieve synergistic effect with radiotherapy, and they don't really add much toxicity. I find ifosfamide is a good example of this kind of drugs, and we give it regardless of the organ. Even in the old days, people were afraid of bladder irradiation and ifosfamide. It's not like that anymore. Some drugs have a synergistic effect, or may have, but they increase the normal toxicity, like doxorubicin and high-dose methotrexate and actinomycin D, and these, of course, has to be taken in consideration. Also, which organs are being irradiated concomitantly with which chemotherapy. So this has to be taken in consideration. Now there are new drugs coming, and sometimes maybe not in bone sarcoma, but sometimes I feel a bit reluctant to give if I lack the data of if there is any interaction between the new immunotherapeutic drugs and radiotherapy. So one has to be a bit careful in certain cases. Next slide. The timing of radiotherapy in Ewing sarcoma is interesting also because in North America, the local therapy starts after 6 cycles of VDCIE. While in Europe, it starts after 9 cycles. And actually, I was not aware of this difference until very recently when I looked the protocols up. I don't know if it makes a difference, but I mean, it's an interesting point anyway. In the rib tumors with pleural effusion, the hemothorax is usually should be given as part of the local therapy. So you start with that and then you add the boost. And for whole lung irradiation, it is avoided, and it is written in the Ewing protocol, contraindicated after high dose chemotherapy and stem cell transplantation. It's interesting, however, to notice that there is one study done by SSG and the Italian Sarcoma Group, where they have given 15 gray whole lung irradiation after stem cell transplantation, but they waited from 70 to 90 days before giving after the high dose chemotherapy, before giving the radiotherapy. So it's not to say people have to do that, but it's interesting that we have some data that one can do it, but they need to wait for such a long time. And for irradiation of the oligometastasis, it's usually at the very end of the treatment when they finish the chemotherapy. Next slide. Good. So I have now talked about almost everything that I can in a very short time: the timing, the radiotherapy dose, the margins, the indications, the results. What would we expect? What is the local failure data that we have? I mean, if you look at the European old studies, the first column here, these are studies from the 80s and until the 90s. The local failure for surgery only 4%, around 4%, with surgery and radiotherapy together. Post-operative, it's 10%, and for definitive radiotherapy, 26% local failure. But the recent studies, it's better. Still, you can see the same trend of having best results with surgery alone. And then with definitive radiotherapy, the local failure is highest, but it's better than the old studies. And in the American studies on the right-hand side, the last study shows, again, more or less the same trend, but again, much better for the definitive radiotherapy alone. So there is definitely improvement in our technique and in our selection of patients that probably leads to that. And with the new studies, the new technique, and with the dose escalation, I hope that these results will even be better. So this is, I think, the part of the Ewing sarcoma. Shall we go further? Yeah, I have an example. I mean, I think this is an interesting case. This is a girl, 18 years old, presented with medullary compression because of this large tumor, as you can see. Here, it grows through the intervertebral column into the spinal cord. It was operated to take a biopsy and to reduce the pressure. She got chemotherapy. She is then operated again, and she was referred to post-operative radiotherapy. Because of this large tumor and the pleural effusion at the start, we thought she needs to have a right hemithorax, 18 gray, and then we will have to add radiotherapy to the tumor bed up to 45 gray. We needed to combine photon and proton therapy in this case because we could not give the hemithorax with the proton at that time in our department. So next slide. So I think you can see here on the left hand side the tumor, and this you can see both the orange line. It's the tumor bed with margin, and then you can see I think the green line. I'm not yeah. The hemithorax volume. It was a sort of a pleural irradiation. We tried to save the slight dose in the center of the lung because it's not the parenchyma in the lung, but the pleura. And we managed that. So she got a sort of hemi-arc technique to treat the hemithorax, as you can see on the right-hand side up above, and then the boost with the proton only to spare the rest of the lung up to 45 gray. So we managed this combination. We had to make the scan in our department and the fixation, and use the same fixation and the same scan in the photon department to be able to combine both. Next slide. So this is the part regarding the Ewing sarcoma. I would like to go into radiotherapy of osteosarcoma. Next. The indications are not much different than the Ewing sarcoma. I mean, there isn't in the Aarhus protocol, which I used as my template here, there isn't an indication of preoperative radiotherapy. I never tried that in osteosarcoma. So it's postoperative radiotherapy, definitive radiotherapy, and radiotherapy to oligometastasis. And it is the same as in Ewing sarcoma. When you can see it, it's the positive surgical margin. It is if the surgery was not adequate in the soft tissue, not only in the bone but also in the soft tissue. If there is a high risk site like the pelvis, the paraspinal area, the craniofacial part, and after pathological fracture. The definitive radiotherapy is in cases when it is irresectable or the patient refuses the surgery. And the radiotherapy for oligometastasis, it's the same as in Ewing as well. If feasible, we try to do it. Next slide. So doses and margins. I mean, in the table here, you can see, according to the Aarhus protocol, the margin that you add for a CTV1 and a CTV2 and maybe a CTV3. Notice here the difference is that for Ewing sarcoma, you have two volumes, one defined by the pre-chemotherapy volume, and one is defined by the post-chemotherapy volume, where you give the boost. In osteosarcoma, the margins are defined around the initial GTV. It usually does not, I mean, it doesn't regress that much, especially in the bone. So the margins are, according to Aarhus, always defined according to the initial GTV. And then you add a margin of 1.5 to 2 centimeter if it is an adjuvant setting for 50 gray, and then you cone down to 1 centimeter to 60 or to 66, and you can even cone down with a 0.5 centimeter margin to 68 or 70 gray. If you will give definitive radiotherapy, you can use one margin with 1 to 2 centimeters around the initial GTV and try to give as high as 68 to 70 gray. This is what is written in the Aarhus protocol. However, I mean, for definitive radiotherapy, you can also have two volumes. I mean, a larger volume with 60 to 66 and a smaller volume to up to 72 gray or 70, according to what you can give in this case. As I showed in this example here, where you have a sarcoma in the sacrum, where you have two volumes, one 66.6 and the other one for 72 gray, as a definitive radiotherapy in this case. So this is in a nutshell what you a suggestion of what you can do for treating osteosarcomas. with radiotherapy, both adjuvant and with definitive radiotherapy. Next slide. The timing, as I said before, contrary to Ewing sarcoma, there is no data to support early administration. Then you can give the whole chemotherapy first, and then you give radiotherapy without any concomitant chemotherapy. This is what we often do. Next slide. So this is this concludes the osteosarcoma part. So now we talked about the chemosensitive bone sarcomas, the Ewing and osteosarcoma, and the role of radiotherapy in these two diseases. I briefly try to, without spending much more, without being too long, go into the chemo-resistant pediatric bone sarcomas. Next slide. The examples are chondrosarcomas and giant cell tumors and chordomas. They are usually treated surgically. Radiotherapy can be given to chondrosarcoma postoperatively if the operation is not radical or radically if the tumor is irresectable. And we use more or less the same doses as we do with osteosarcomas. So the concept is not much different, apart from that we don't use chemotherapy as much with chondrosarcomas. There are concerns regarding radiotherapy for giant cell tumors. The risk of transformation, second malignancy, and things like that. So it's not often used, especially after we have denosumab as integrated drug that used often in treatment of these diseases. So we start always with denosumab and surgery, and the role of radiotherapy seems to have been retreated to the background in these cases. Next slide. So let me talk about the sarcomas of the skull base, and of course with the focus on chordomas. Next slide. For skull-based tumors, the treatment strategy is and should be at a trial of an optimal surgery in a specialized center. These are very difficult tumors, and I would very much recommend to refer them to specialized centers for both radiotherapy and surgery whenever possible. And this surgery should be followed by radiotherapy. So this combination, in my mind, is a treatment of choice. The surgery should be aiming at R0 resection, but we know it's often not possible, and R1 resection with preservation of neurological function is, of course, also acceptable. It is important when you would talk with the surgeon to try to get to know how much, if there will be a residual disease, how much this will be. Because as you can see from the right-hand side, the local control probability depends much on how much residual disease after surgery there is. So you can see the good prognosis for GTV below 25 milliliter and poorer prognosis, poorer local control for larger residual disease. One can sometimes think of a surgery that enables the radiotherapy in certain cases where the disease is very close to the brainstem in such a way that you will not be able to deliver enough dose to the tumor without compromising target coverage. And in this case, if surgery would enable you, would create a space to give the needed dose, then one can also opt for that. We also urge our surgeon, when we look at the post-operative images, if there is a disease that is easy, the lifted disease that is easy to remove, they would come again and remove it. We are a proton center. We treat with protons, and we are keen on not having implants with metals that hinders the use of protons. So we need also to discuss that with the surgeon before the surgery. And sometimes they do two surgeries: a surgery to remove without fixation, and the patient will come with what do you call it? I mean, with something to support the neck, get the radiotherapy, and go back and make the fixation after. We give, of course, radiotherapy radically for inoperable cases, and we do all what we can to achieve cure from the first step, because we know that local relapse has, unfortunately, a poor results, and survival is poor after that. Next slide. As I said, it is challenging. It's challenging because the optimal target coverage with the radical dose of radiotherapy that is very high, while observing constraints is sometimes challenging, and we need to accept in many cases compromises. Generally, I don't think below 6 gray can actually achieve cure if you have a gross disease for these diseases. The usual dose range is usually 68 to 74. People give more than that, I know. I'm not sure if there is evidence for how strong the evidence for doses higher than 74 gray, but I know people give 78 and 76 gray. The minimum dose required, if you have a very low risk area, like the area where there is a surgical tract, it can be 54 gray. So these are the like the dose spectrum used to when you deal with these diseases at this site. Next slide. I think this article is very nice because it has described the experience in many patients, 204. The usual doses that we use, 76.6 RBE as a median dose for these patients were delivered. It's an article that describes a long follow-up with median overall survival and progression-free survival of like 25 years. And the results are very nice. The 5, 10, and 20 overall survival of 84, 80, 74, and 78. And the progression-free survival is also around 60, 64 after 20 years. So it's a nice cohort that describes the practice and what we can expect of. They have recurrences in 27% of the cases. 42 of them were within the first 3 years. And the major, I mean, more than 50% when they relapse locally. The relapses in the surgical track is not high. It's 6 patients, which amounts for less than 5%. Next slide. For this group of patients with these doses that has been given, they describe some tolerance constraints in the article, that they accepted a maximum dose to the surface of the spinal cord and the brainstem of 67 gray RBE. And the maximum dose to the center of the spinal cord and brainstem is 55 gray. And the maximum dose to the optic chiasm and optic nerves should not exceed 62 gray. These are higher than what we use in Aarhus. So it's again, it's a description of what this department has used and what they accepted. But I mean, each department has to have the constraint that they feel comfortable with and they can use, because ours are less than that. It's interesting to see that, and to see that the brainstem injury reported in this article is like 2%, and it's kind of radiographic and symptomatic. The temporal lobe injury is about also 2%. So with these constraints and dose levels, this is what they expect and get. Next slide. Because of this challenge of having to deliver a very high dose, and to the target, and also respect constraints to critical organs. People try to have a strategy. What kind of strategy should we use? And I found this, again, this article interesting in its concept. So you can use it for inspiration. You don't have to follow it, but I mean, just use it for inspiration. They have a high risk CTV, which is the post-operative GTB. So it's CTV is the GTB. They don't add margin to that. So it's the post-operative GB or the post-operative surgical cavity if they have removed the whole tumor. And they aim to give 37.8 gray with this coverage, 95. And there is a low risk CTV, which is the high risk plus 5 millimeter margin, plus other things like the whole cleavage, the cavernous sinuses, the sphenoid bone if they use a transnasal surgery, or the first 5 millimeter of postpharyngeal. So this is a low risk where they aim to give 52.2 gray. And what they do is that they say, okay, if we can deliver this, now you see this red circle under the dose adaptation. If they can achieve that, at the same time respect the constraint in the other red circle under the brainstem and this table, where for less than half a cubic centimeter, they have a surface dose of 64 gray and central dose of 55 gray. If they can respect that, if they achieve that, well and good. If they can't, they will go down to the next dose level. They will reduce the dose to the high risk CTV to 72 and see if they can hit this balance. If not, they will go even lower to 68.2 gray. And if they can't, then they will elevate the level of their constraint. They change the constraint, the same dose level, but to a higher volume, it's a larger volume, and see. So this is an interesting strategy where they move around this balance of trying to give a very high dose to the target and respect the constraint as well. So this is, again, something you can use for inspiration, not necessarily follow them blindly, but inspired by in your own practice. Next slide. A small point just to remind you, when you read the articles about the brainstem dose, and they will describe the surface dose and the central dose or the core dose. And what is the surface and what is the core? I mean, there isn't a lot of description about that. And it's not anatomical in any way. There isn't any anatomical structure that describes that. It's a trick. It's a way to make the dose gradients in the brainstem. So some will just put a 1 millimeter circle in the middle, and they consider this is the center. The rest is surface. Some will take 3 millimeter from the surface, and anything in the center is the brainstem center, core, and in the periphery, this is the surface. And some use 2 millimeter margin. We started in the CPT in our department by having this 2 millimeter margin. So there are different ways of delineating what is a surface of the brainstem and what is core of the brainstem. Next slide. I have some examples here. This is a case of chordoma in the base of skull, and you can see on the right-hand side the large tumor before the surgery. The surgery was done. It's radical. They didn't leave anything, and this and then you can see the high CTV volume that I draw around this tumor based on the images before the surgery. Next slide. This is another case. This is again a tumor. You can see it on the left-hand side. This is another chordoma. It was operated, but the tumor was not. The surgery was not radical. So next slide, you can see the residual disease delineated in red. And so the volume that represents the surgical bed is the large one, and then the small red ones are the areas that on the MR showed the residual disease. This is the GTV, and now the CTV. And next slide. both the very high dose, the one in the red that represents the residual disease after the surgery with a margin, and then the GTV, the CTV of the preoperative disease with the appropriate margin. Next slide. So this is my take on the brainstem tumors and how to deal with them. There are, of course, general strategies to reduce the risk of severity of late effects. Some can we apply, some we can't. I mean, a famous strategy is to reduce the total dose, but it doesn't seem to be a possible strategy in these cases because it needs risk stratification. It needs a more effective systemic therapy that's not always possible in many of these cases. And the current sarcoma studies usually are testing dose escalation and not dose reduction. So there is a need generally in the field that we need maybe for high risk patients to add more dose. You can reduce the volume of the normal tissues, receiving high volume, high radiation dose, like using less margin, like the current interviewings that have only 1 centimeter to the pre-chemotherapy and 0.5 centimeter to the post-chemotherapy. The modern radiotherapy, using IMRT or proton, we reduce the volume of tissue, normal tissue, getting the high dose. Reducing the normal tissue volume that receives the low radiation dose is also important strategy, and it will also lead to a reduction of the both acute and late side effects. And you can do that by proton therapy or by brachytherapy whenever it's possible. I know it's maybe not for these particular cases, but for bone sarcoma, but for soft tissue sarcoma, brachytherapy can be helpful in that. Next slide. Good. I mean, a few words about the low and middle income countries. I mean, I'm originally from Egypt. I started my specialization there, and I asked myself now with my experience here, if I go back in years, can I do something different? Would I have done anything different, knowing what I know now? I think the message is, for anybody coming from a low and middle income country, please lobby for centralization of treatment. I think this is a very cost-effective way. It's the cheapest solution on the long run. I think any country, regardless of its economical situation, can afford to have at least one big center, national center, where experience is gathered, where resources are being put. And I think this is really the best way to treat this rare disease, whether we talk about bone sarcomas or children's sarcomas or sarcomas in general. I mean, whether the pediatrics or the sarcomas, both are rare disease and need experience. And as I said, I think it's cost effective and the cheapest way. It's also politically neutral endeavor. I mean, regardless of the regime, it is always attractive. It's always a good project nationally to have a center to treat all the children and gather the experience and give the best way. So try to do that. And regarding the radiotherapy itself, I think one can try to invest in proper and maybe innovative fixation method. I mean, I think now back to my 80s, my 80s years when I started my radiotherapy, I think what I believe we didn't do maybe as good at that time in Egypt when I was young was to focus on that, to fixation, because a good fixation is really, really important. It's cheap, it's important, and it's simple technology, and it will improve the accuracy and improve the outcome, and can allow for a smaller margin and less complications. I guess this is the last slide, isn't it? And I hope this is our center, just a picture from inside. And I hope I didn't shoot beside the aim, as they say. What I presented is what at least the majority of you wanted to get out of this lecture. Thank you.
Thank you, Akmal. I think this was really great, a very insightful talk, highlighting many things that people dealing with children with bone sarcomas need to know. We do have a couple of questions in the question answer, and I would request the participants to write if there are any questions or comments in the chat box. So can I read those questions for you, Akmal?
Yes, please, because I mean, yeah, I would rather, yeah.
So there's a question about in case of long bone with intramedullary nailing, I believe, which is done intraoperatively or before starting the treatment, although in cases where there's no intramedullary involvement upfront, does this intervention modifies our low risk CTV? Like if a surgeon does an intramedullary nailing, but the tumor extent was not as much as the extent of the intramedullary nail, how do you manage your low risk CTV?
Now, can you repeat the question again? Because I thought I misunderstood at the beginning when you continue. Can you repeat it
So
again?
in case of a long bone with intramedullary
Yes.
nailing done intraoperatively, although no intramedullary involvement was present upfront, does this intervention modifies our low risk CTV?
I wouldn't, but I would rather. I mean, I would like to hear if anybody else has an experience, or whether Beata would consider that an indication to increase the volume. I don't think it does.
So I think the question is if we would include the nail or the
Yeah,
part of the bone
yeah,
with a nail. No, I think we would not do it in that case.
yeah.
So I think this is pertinent to the situation when somewhere there is a pathological fracture because of Ewing sarcoma of proximal tibia, and an non-oncological intervention is done upfront, that a nail is put into the whole bone before starting chemotherapy. So that was, I believe, the question about.
Well, I mean, it's difficult, really. I mean,
Yeah.
Again, I don't think I will change my answer, but I mean, we need sometimes to look at the images and see how big the disease was and the soft tissue and where the nail started and in. And I mean, but I mean, in principle, I mean, this shouldn't change the CTB.
Yeah, I think the question is if there is a risk if that you kind of distribute or spread tumor cells by putting the nail. So therefore, I think you would look at where was the nail put and did it go through some tumor-bearing area, and then you may include it. But if that's not the case, you would not do it whenever it would have been put. That's my personal understanding of the
but this is what I said when you have to look at things sometimes, because it's difficult to have a general rule. But I think it's the observation is interesting and the question is intelligent and is important, and you need to consider that. But I unfortunately I don't have a recipe that apart from what Beata said, that if you think this goes through the tumor, you may you may want to increase, be more generous at least. But
so this is particular a situation that Akmal, I had to deal with a lot of times where the patient had a pathological fracture because of the tumor, and there was contamination of the whole medullary cavity done by putting in a nail through the tumor along the. So it's highly difficult to disregard the contamination of the whole medullary cavity done through that intramedullary nail done going through the tumor and distally or proximally. So no, but there are other questions.
But I mean, Bilal, I mean, respect your clinical judgment, and I understand. That's why I said it's an important question. It's an intelligent question. It touches upon a real issue, and if your clinical sense tells you this is needed, then I think you should do that.
So there's a question about marginal how do you define marginal or inadequate resection margin for Ewing sarcoma? You did have a slide on that. So how do you define marginal or inadequate resection?
Well, I mean, I use the term inadequate to lump together the situation where you think there is a high risk. The simplest is the R2, where you have a macroscopic disease, the intralesional, the R2. And then you have the R1 when you have microscopic disease, that's to say that you cut through the tumor or at the edge of it. So there is no margin. There is no margin, not even a millimeter. But then you have a margin. The margin when you go through what we call the pseudocapsule, if you manage. And the problem here, of course, is to define it in terms of millimeters or centimeters, because it depends. If there is a fascia that separates the margin from the tumor, then you can accept 5 millimeter, and you consider that an R0 state. But if there isn't any, 0.5 millimeter is considered margin, at least in Aarhus here. So it has to be more than that.
So the next question is about the dose of 54 gray versus 59 gray. And Dr. Peter asks that concerning Euro-Ewing protocol, is there a significant difference with the radiotherapy dosing with patient outcome when a dose of 54 gray versus 59 gray is used? What was the rationale of different in the doses?
The 54, I mean, gray is used for tumors less than 8 centimeter. The 59 is for tumors more than 8 centimeter. So it's a size question here. But there is also I mean, I won't talk about the dose escalation, but because you have to be in the protocol to do that. But I mean, you have a maximum of 60 gray as a standard for the tumors that are large, more than 8, and 54 for smaller tumors. We can go to 64 and above that, but this is experimental.
Yeah, maybe Akmal, because I was or I am the chair of this protocol with regard to RT, so it was my invention, let's say, this strategy. So the truth is that we don't know the optimal dose. So what we did is that we tried to define several risk groups and then looked into the literature. What is the dose range given for those scenarios so far? And we found that for all the risk groups, we had a range of about 9 gray to offer. So therefore, we decided finally to randomize, let's say, the lower edge of this range compared to the upper edge of this range. And this we did for all risk groups. There is very little data on the optimal dose for the very high risk group with gross total disease. There is some group from an Indian data from an Indian group saying that the higher dose, which was I think it was 68 or 70,
around 70,
was superior to 59 or 60 gray, and that was the only group where we had some randomized data available, but still this was early data just in an abstract. So I would say we don't have the data, we just compare different dose levels which were already given worldwide, but with not knowing what is the best. So we try to find out the best dose, high versus low. Let's put it like this.
Yeah, I think it's the Tata Memorial data from Siddharth, about 70.2 gray.
Exactly.
And then we have the St. Jude data of 64.8 gray.
Yeah.
So somebody asking to have access to this nice presentation. So Akmal has already agreed to the recording, which would be available.
And also the slides, if you can send it to everybody.
Yeah, sure. And the recorded lecture would be available on the YouTube page of PsyOp. So the attendees may be able to get that. So the next question, Akmal, we have crossed the time, but are you happy to take some more questions?
Yeah, of course, of course.
Okay, Beate, is it okay to proceed with that?
Good.
Yeah. So in case of bone sarcomas, how to handle the lymphatic corridor? What percent of lymphatic corridor is to be spared, and what low dose isodose curves to evaluate in such a scenario when treating with photon?
Well, I mean, very difficult questions. I mean,
So I think,
there are
yeah, I
things that
think
we do.
this is about the long bones when you
Yeah,
have
I
a
know.
circumferential.
I say because again, there are so many different practices and ways of doing things. Um, so I mean, in Aarhus, for example, I mean, we are testing different things. I try to see if we can get constraints to exactly to answer this particular question. We have a group of patients that we have followed for a long time, and we have the dose plan, and we try to correlate what we can see as late effects with different things. So you take it like 2 centimeter corridor below the skin, um, all around the limb, and then you try to save like 30% of this, and not to exceed 30 gray to this volume. I mean, test this parameter whether it correlates with the late effects. So this is one way. Some they will take the whole subcutaneous fat until the fascia, regardless of the number of centimeters. Um, some try to like spare the medial part if they can. So I mean, there are different strategies. I don't think we have clear way of defining it. One can say try to spare 1/3 of the circumference and not to give more than 30 gray. But this is a very rough way of saying things. I wonder if, I mean, Beata, do you have any particular
No,
constraints to
we
this?
don't treat a lot of extremities with protons, but with photons, we followed similar rules as you were saying, like spare at least 1/3, better 1/2 of the circumference, and avoid doses higher than 30 gray. I think that's more or less what we did when treating extremities.
Yeah, yeah.
So this is a question regarding photon versus proton, I believe. Is it possible to achieve and perform a similar treatment with photon? Obviously, will be challenging related to the organ at risk doses, but what would be your recommendation about it?
This is again a difficult question. I mean, if you compare those plans, it needs no, I mean, it's obvious that you will always find lower dose with the proton plan. I mean, the question, the 100 million, is whether it is clinically significant. And this is not an easy question. I mean, generally, I would tell you in Denmark, we say children, protons. Children equal protons, unless there is a reason not to. Palliative cases or the patient cannot. I mean, there can be reasons, of course, but I mean, like the default is that because we expect the children, when it is radical treatment, to live long generally, and we would like to spare them every centigrade. So that's easy. That's not. This is one strategy. But then when you get to adults and you start to having difficulty because you don't have criteria that is clear. So one thing is to use the NTC CP models. So to have models, there are models to guide you what to expect. The dose to, let's say, the PCM muscles of the pharynx. I mean, the expected dysphagia that will come out of that. There are data from Holland that can give you an estimate. So you can do a comparative dose plan, and you can then estimate the risk of dysphagia based on that for head and neck cancers, for example. And then you set a level you say, if there is a sparing of more than 5%, which is again something you put locally, then the patient will get protons because you have some data to say that the reduced dose have a significant effect on a particular side effects or late effects that you would like to avoid. So this is a model that we use in Aarhus. I mean, we have, and this is done by the group that treats the head and neck. They put a criteria to which patients should get protons based on the expected toxicity. And then you end up with a group of patients in which you have reduced dose, but you are not sure of the outcome. And in Aarhus, at least in Denmark, we say, okay, these patients should be randomized in a clinical trial. So there are clinical trials trying to answer these questions, again, led by the different groups that are treating the different diseases. And sometimes then in certain cases, you find really no data to say that there is a difference in late effects of significance, and then these patients will get photons. So comparative dose plan using some models to estimate the late toxicities and the clinical trials. These are the methods, the tools that we use to choose whether a patient would get proton or photon. Beata, you want to say something?
Yeah, I think that particularly now for the LMIC audience, I think it's important to achieve the dose coverage and to spare organs at risk sufficiently with a good dose gradient. And if you have a tool different from protons, like a good IMRT plan, you can achieve similar results with regard to coverage and dose fall off, because this is the major problem with the brainstem, that you need a sharp or good gradient of your dose. But I think the problem is more that people with photons do not dare to use similar dose constraints. So typically they are more conservative giving dose for particular for the brainstem, and therefore they cannot achieve a similar dose coverage. But if they would use, or if you would use with a good photon tool the same dose constraints, I think you could also treat such a case, and you would need to try to do it without protons. And there was one paper from I think PSI group in Switzerland showing that for chordomas, for example, the volume receiving 66 gray or more was the most important factor for tumor control. So you need to cover a good proportion of the volume with very high doses. And if you have a tool to achieve it, you should go for it. You will not have protons in most of your countries, but you need to try to adapt to the dose constraints and to the coverage aims in order to achieve similar results.
Yeah, I was not focusing on the LMC, low and middle income countries, and you are right. And it's important to say that exactly that photon plans can be extremely good, and you aim at the coverage and the constraints. Of course, if you achieve that, it's marvelous. You should do that.
There are a few more questions, Akmal. The next one is about how do you decide for radiotherapy to the metastatic sites in Ewing sarcoma, and what dose would you use?
Okay. Well, I mean, again, this is an area where there isn't much data, but I mean, again, because the protocols of every or any guidelines would say whenever feasible, and the question is when it is feasible. So, I mean, I would. I mean, there isn't. I mean, the concept of oligometastasis is vague, and because oligo will give you, I mean, suggest few, which suggests a particular number, but we don't have a particular number, and you cannot just use 3 or 4 or 5. I mean, 3 metastases in lung are different than 3 metastases in 3 organs, I believe. I mean, at least this is my clinical sense. It tells me there's something different. So it's not only the number, but anyway. So whenever feasible, I mean, the patient has, I mean, for me, I would finish the radiotherapy, the chemotherapy part, look at the number of metastases that are visible at that time. I think this would be my priority, to irradiate these sites that are still active and visible. I would consider the volume that has to be irradiated, the expected side effects out of that, and particularly after such a long treatment of chemotherapy. And then I will give the radical dose, but I don't have to give like 5 weeks of treatment. I can use hypofractionation, choose something that equivalent to what is around the 50.4 or 45 gray. Would you do that, Beata?
Yeah, I think we try to achieve 45 gray at least. And so we have a kind of a limit saying we should not irradiate more than 1/3 of the hematopoietic bone marrow. So as a kind of idea. And sometimes we restrict to the ones being active in PET-CT, that you select the ones who are most active in PET-CT. And if you have too many, then of course you should select according to either symptoms or to threats like a nerve palsy or fracture or whatever. So I think you have certain criteria to select some in case you are not able to treat all. And that's what typically is discussed then.
Yeah, I think there are some data, although not very large, not in Ewing, but in rhabdomyosarcoma, about that irradiating some of the metastases still give results. So if you cannot treat them all, just treat what you can.
Okay, there is a question about using denosumab in pediatric population in pediatric age group, like in osteosarcoma, to stop bone destruction.
I don't have experience with that. I mean, I have one experience with what patients, in pediatric patients who we gave here denosumab, but it's not my department, of course, but I was involved in that case previously. And I mean, for me, and it was giant cell tumor, it was not osteosarcoma, so I don't have experience of using denosumab in osteosarcomas, and I don't think that it is indicated to use it. But anyway, my point, what I got out of this particular case that we followed with the pediatrician, and is that you can use it. I mean, it seems to be, at least in this case, safe, and it has been used for a relatively long time. And the child was, I think, around 12, and she's now maybe 16 or something. So there is, you can use it in children. But the timing, the dosage, the interval, and how you reduce the dosage, I'm not an expert in that. So I'm sorry not to be able to answer.
So would you agree for radiotherapy as part of osteosarcoma treatment plan in children for those who have not responded to systemic treatment or who relapsed?
I mean, instead of surgery or
yeah, it seems like that.
Context.
He's asking about that.
I mean, the treatment of osteosarcoma has to be multidisciplinary. So it's difficult to give an answer to question when I'm not sure why it's. I mean, have we used all other possibilities? I mean, is that instead of or together with? I mean, my point is, I mean, yes, we can always use radiotherapy. There are indications, as I tried to explain if it lies within these indications, so it is indicated, but there has to be part of a multidisciplinary treatment where surgery has to be considered, chemotherapy has to be considered.
Akmal, maybe one part of it is about relapsed patient, and I would just assume that the other part is about those patients who you do not have a good response, that you could spare the limb, and amputation may be an option for that patient only. So would you go for radiation instead of amputation?
I mean, an osteosarcoma patient that progressed under chemotherapy, I would feel reluctant to just use radiotherapy if surgery is possible. What do you think, Beata? Do you agree, or do you have another meaning about that?
No,
I mean, my feeling is that it will need surgery.
Yeah, I would always first try to attempt surgery.
Yeah,
Okay.
especially if
So,
it progresses under chemotherapy. At least this is my feeling.
so now the next one is about patient for Ewing sarcoma with one pulmonary metastatic lesion. Would you recommend whole lung irradiation, hemithorax, or local
Yes.
treatment only for that
Yes.
metastatic?
No,
Which one
I
of
wouldn't
the
give.
three?
I mean, I'm but I mean, lung metastasis. I mean, I would give the whole lung irradiation. I mean, of course, it is you can remove the metastasis. You should do that or give stereotactic to it, but this does not replace the whole lung, in my view.
That essentially is because when you have one metastatic deposit in any lung parenchyma, you probably have micromets which are not visible. So for osteosarcoma, is radiotherapy considered for curative intent or palliative intent in the setting of patient's refusal for surgery, considering osteosarcoma is an
Your
invasive
voice,
tumor?
I'm sorry.
Yeah, so I think you have already answered this question with the previous one, but just again, question regarding osteosarcoma is would you consider radiotherapy for curative intent or palliative intent in the setting of patient refusing the surgery, considering it is a radio resistant entity?
I can't hear.
Yeah, I think I can say so. The question is if you cannot operate or patients don't want you to operate, is radiotherapy still a curative? And so I would like to answer this question because there was a, let's say, smaller series from Germany, from Berlin, where they treated children with osteosarcoma after a parent's refusal. And it was striking that about 50% of them survived, even receiving relatively low doses like 50 to 60 gray. So I'm always saying, despite the fact that this is considered a very radio-resistant tumor, you can still cure some tumors with radiotherapy alone. So I think it's still worth to give it a try. Even if we all push first for surgery, if they can't do it or if parents don't want it, we should try definite radiotherapy. You can have curative results.
Okay, so can you hear me
Thank you,
now?
Beata. It's nice to know. I mean, we also do that. I mean, half-heartedly, I must admit. But yes, sometimes we are obliged to do that if there is. I mean, if they refuse local therapy with surgery, we need to give them the best possible chance, and this is with high-dose radiotherapy. Yes, but I can't say that I have a big experience with that.
Okay, can you hear me? Yeah,
No, sorry.
so can you hear me now?
Yes.
Okay, so the next question is about the European versus the American strategy regarding the number of cycles of chemotherapy.
Yes.
So the Americans give 6 cycles of chemotherapy and European 9 cycles before local treatment, I believe, and you might expect better response rate in the European strategy of 0% of viable tumor cell, I believe. So are there any comparable data whether the response rate to chemotherapy is better in the European protocol for Ewing's?
Not as far as I know, no. I mean, I don't know the data exists. It may, but I mean, I don't have hands on it, and I
Yeah.
haven't read it somewhere. And to be honest, I didn't look for it. So to be honest, also, I mean, there may be data that I'm not aware of.
So I had some
But may I
discussion.
say something? May I say
Yeah, yeah,
something?
yeah.
It's important because this is new. I mean, previously the European we would give a different chemotherapy than the American. It's
Right.
only after Eurowing 2012. So this we need to look at the 2000 and that Eurowing 2012 data to be able to answer this question, which I don't think they have looked at.
Okay. The next one is giving radiation in cases of Ewing sarcoma of the thoracic wall with pleural effusion. Would you give the local cross tumor and hemithorax irradiation in one single phase, or give it in a separate phase, that is like local treatment first, then hemithorax in a different dose per fraction. So what would be the sequencing, like a local and
Yeah,
the
but
whole
this is
lung
what I
together?
tried. Yeah, this is what I showed you in the example where, I mean, we had the hemithorax and the tumor together to, and we with 1.8 gray per fraction up to 18 gray. And then we just focused on the tumor part and added an extra 27 gray to each to reach 45 gray. So this was the case that I showed you. And this is what we will try always to do, to get the hemithorax together with the primary tumor, 1.8 gray per fraction, and then focus on the small one.
Yeah, so Akmal, I have a question regarding it. Like two things I want to say here. Like Americans do the same, like whole lung hemithorax radiation first, and then the pre-chemo extent, and then the post-chemo residual tumor if it is not resected. So the question I have for you is that the Europeans do 18 gray and 15 or 15 gray, and the North Americans do 12 gray and 15 gray. So the 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 doses are a bit different. Any thoughts about that from your side, or Diate, for hemithorax?
I'm not sure.
This is the
I mean, you
question
asked
I'm
me
asking. Yeah.
to me and
This is
to
the
Tibiata.
anyone. Any thoughts
Okay,
about
so
that?
you are talking, you say the Americans are giving different doses for the
Yeah,
hemithorax.
yeah.
Okay. Well, I'm not, I mean, I was not aware of that, to be honest. So this is something new for me. I'm not, my belief has always been that whole lung irradiation and like hemithorax irradiation, there are elements in it that is not just a direct cell kill because the dose is low. And there might be something regarding the microenvironment of the irradiated tissue that makes it hostile to cells or immune response or something like that. So it's not like the definitive direct cell kill that we know when you give a high dose of radiotherapy. I think it works through slightly different mechanisms. And if this is true, but it's just a theory, if this is true, then maybe 12 or 15 gray doesn't give much difference because again, the mechanism is not related to the high dose that you expect. You don't see a direct dose response curve as you see with the local treatment. I don't know if this makes sense, but this is how I think about it. If anybody would like to add something, I would love to hear.
No, I don't.
So I
So
mean,
maybe
so my theory now is on air.
well,
Everybody
well,
knows about it.
okay. So the last three, thank you for holding back and answering all those questions. So about Ewing sarcoma, what about irradiating the whole lymphatic station when interested in a single inguinal node with a primary lesion located in the subcutaneous cutaneous tissue of the low lateral side of the abdominal wall? The surgeon did not want to do an entire inguinal dissection, so till what extent RT should be. So maybe it's talking about a single node, and that node alone is taken out. The surgeon does not want to do uh, the entire nodal dissection. How would you irradiate?
Well, I mean, I don't think there is enough evidence here, but I mean, usually I take the anatomical
That's
area. If
it.
it is inguinal, I irradiate the inguinal. If it is iliac, I irradiate the iliac. I mean, I'm generous in that sense. Um, um, and if there is a surgery and the surgery is, I mean, big, then I reduce the dose, not the volume. I mean, I give the lowest possible dose if the surgery is optimal. If the surgery is just a biopsy, and then I opt for higher dose. But the volume I keep to the regional site. And I don't think I can say that I have evidence for that, but this is my practice.
So any experience on hypofractionated regimen for sarcomas, since there is some data coming in for adult sarcomas?
No, I don't have experience with that. I don't use it for primary treatment, for irradiating the primary site. I consider it for oligometastasis. And these cases are very few, and I don't have like standard thing, but it depends according to the case. But I give what is equivalent to 45 gray at least.
Yeah, we also give equivalent doses, but we only use it in case of progression under radiation therapy. Sometimes we see progression when during our course, and then we may start to go with some hyperfractionation, but we have no evidence. It's more a gut feeling that we want to do more to be faster, and yeah.
So what is any experience about lattice radiotherapy in palliative setting in Ewing's or osteo?
We still consider, no, don't have one, no, but and we had just had a meeting yesterday discussing grid and lattice and everything else. And no, but I wonder if Beata has. No.
So one last one, Akmal, could you explain the brainstem surface and core a bit more? Acceptance criteria, how it will be different. I believe this is more question like during your talk, I heard from my resident, like, why don't we do it in photon? I told her that we do a PRV. I don't do proton. So maybe it would be a learning for me as well.
Well,
I mean, a lot of questions coming in from my own residents.
Well, I'm happy it initiated such a big. Well, I mean, I must tell you, this issue now in Aarhus is a very hot topic, and we are keeping discussing it. I have slides that keeps growing because I add every day a new slide with the new constraints that I got from somewhere, to try to sit down with my colleagues and reach a consensus here what we feel comfortable doing, because it's really difficult. And when we started, we had a very, very conservative guidelines, and it served us fine. So we were happy until we got a case where we felt this is not, this coverage is not optimal. We need to change that. And we felt the urge to be more aggressive and have another concept. And then we start looking and doing that. And as I said, the surface is not defined. What defines the surface? And I give you in my lecture 3 different ways of doing, of delineating a surface and a core for the brainstem. And then even, I mean, when you agree on one way of defining what is a surface and what is the core, then you have different constraints. What would you accept? Dose max to a pixel dose to pixel volume, or do you accept the D2% or the D50? Or, I mean, I don't have a recipe. I mean, you can take the slides, look at it, and see if you feel comfortable with it. I can send you what I already gathered, so you have different constraints from Europe and America. But you need to have your own discussions internally and see what do I feel comfortable with. And then, as you said, I mean, it all depends also on how the technique you are using, the fixation, how sure you are about the accuracy of your treatment. It affects also the choice.
Akmal, when referring to your slide giving those 3 options of the core, so I take the left one, so the one with a small, typically it's not 1 millimeter, it's more 2 or even 3 in the upper part of the brainstem. And I think this is the only way you can go, because if you want to achieve a dose fall off from 67 to 55 or what you gave, you cannot do it within 2 or 3 millimeter. So the middle and right version does not make any sense, because if you want to have a dose gradient that sharp from 67 to 55, you need some millimeters to achieve it. And Therefore, I think you can only use the small core at the left side. And I can just tell that, you know, I was taught to use it from Boston about, I don't know, 20 years ago now. And I feel very comfortable to use it. Or it's not 20. When did it start? I think, no, it's 22. Yeah, it's more than 20 years now. So I'm used to that left version on your
Okay.
slide. And I think that works quite fine, at least
Well,
for us.
well, I mean, I will write down recommended by Beata, and this will give it
No.
enough power. No, thank you. I mean, I can feel also that this is probably the best way to do it, because we can see the difficulty in achieving the constraints. Yeah, that's fine. Is that it, Bilal? Have we finished?
Yeah, seems like that. It's been like
Okay,
40 minutes over. It's been interesting
that's
and
fine.
still,
It was my pleasure. I hope it was fine. I mean, for
yeah,
everybody. I
still a
mean,
lot
it
of
was really.
attendees online. Thank you, Beate,
I'm
and thank
happy.
you, Akmal. Thank you.
Thank you very much. Thank you very much. Thank you very much.
Okay, so
Okay,
thank you for joining. So
thank you.
there's an announcement about the PSYOP membership and the annual congress.
Ah, yeah.
Yeah, so hopefully hope to see you at PSYOP and everyone else there. There's an option to attend the video recording to an online platform as well. So you can visit the PSYOP website for that, for the participants, and hope to stay connected with all the attendees here for the cross-working group and understand and see how we can together improve the pediatric radiation services and research in lower middle income countries. Thank you, Beate. Thank you, Akmal.
Thank you.
Thank you. Bye-bye.
Bye-bye.
Bye.
Thank you.
Bye.